In today's video, we're going over the keys to the treatment of our favorite pathology, frozen shoulder. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists who work at Champion PT and Performance. We are here taking the evidence, breaking it down, delivering it to you. And we also have the experience to help you out. And we've been making mistakes, so you don't have to. We are hurting our patients every day of the week. I'm just kidding. But we have a really good topic today. And I think Kevin is the person who's going to take the lead on this one. What's going on, Kevin?
Not much, man. Just still pumped up to talk about frozen shoulder. It's my all-time favorite condition.
That's pretty big. There's a lot of conditions out there.
It has a interesting name in the phases. It's frozen and then it thaws. Whoever came up with that, it's brilliant, right?
Yeah, I like burning shoulder is my favorite.
And then it melts.
Good pathology.
Yep.
Yeah.
Cool.
All right, let's maybe get moving here and stop wasting people's time, huh? What do you think?
All right, yeah. So we talked about this a lot in the past episode on frozen shoulder about what PTs need to know. But I think the first important key here is getting an accurate diagnosis. So again, we went into a lot of detail on this stuff in the previous episode on frozen shoulder, but you're going to look at a range of motion loss in all directions. And you're often going to see external rotation the most limited, especially up at 90 degrees of abduction. This person's likely going to be between the ages of 40 and 60 years old. And it is a more common pathology in females, but that is with a little bit of a caveat that in patients who also have diabetes, sometimes in that group, it's more common in males. And then a radiograph can help rule out other things, but you don't need a radiograph to rule in frozen shoulder. But it can give you some idea of what they're not dealing with if you are really stuck between a couple of different diagnoses. So, the first key to treatment is getting a good diagnosis. That's, obviously very important.
Yeah. And I think obviously getting an accurate diagnosis is really important for most pathologies we face. But in the shoulder, frozen shoulder is just treated very differently than other forms of shoulder pain. So rotator cuff related pain or like instability. I would say the majority of folks you're going to see in a physical therapy clinic probably have some variety of subacromial pain, rotator cuff related pain, even slap tears. And these are all treated very similarly. But frozen shoulder is just treated much differently, right? So we just want to make sure on the lookout for that because it does have a different treatment. If you are enjoying this video right now, I have something else I think you're really going to love. It is an evidence-based cheat sheet on frozen shoulder. Here's the thing, staying on top of all of the medical literature that's coming out is a pain in the butt. No one wants to do it. But here's the other thing, I'm a psychopath and I love doing it. So I've created this cheat sheet to do exactly that. My promise to you is I'm going to get you up to date on the latest literature on frozen shoulder in under 10 minutes. We go over the definition backgrounds, we go over prevalence as well as risk factors, pathoanatomy, as well as the clinical course of frozen shoulder. We talk about how to diagnose this accurately, as well as how to go through your differential diagnosis to make sure you're not diagnosing the wrong thing. We go over the best outcome measures to use with your patients, how to perform your clinical examination, subjective, objective. Then we go over the best treatments based on the irritability of your patients. And lastly, we round it up with different treatments like corticosteroids, surgery, and some of those interesting treatments you hear about like hydrodilatation, as well as suprascapular nerve blocks. So go ahead and click on the link in the description. This is 100% free. You get instant access. Like I said, I'm going to get you up to date in under 10 minutes. I do the work so you don't have to. It can speed up your knowledge as a coach and clinician. Now, back to your video.
All right. So one thing that I'd like to get your input on, because I know I don't do much of this, unfortunately, in a cash-based setting, but I think there's good utility for it, right? So looking at the clinical practice guidelines, there's an A-level recommendation to give your patient one of these outcome measures. And so the big ones that they had cited were the DASH, the ASES, and the SPATI. So what we're looking at here are different outcome measures that are telling you they're self-reported by the patient. And the first two, the DASH and the ASES, are looking at levels of disability. So the higher the score, the more disability perhaps. The lower the score, the less disability. And then on follow-up times that we administer this, we want to see that minimal clinical important difference to make sure that there is a improvement in their function. And then the ASES is a function score. So the higher score there, the better. So that one is a little bit different. But, I do think these are important to use. I think for insurance reasons for people, that's a big consideration. But I also think it's important because these are being reported by the patient. So if your patient is struggling and they don't feel that they're making much progress, but you give them one of these outcome measures and they actually are showing a pretty significant improvement, even a small improvement that hits that minimal clinical important difference is something you can say, hey, look, Dan, I know you're bummed out. You can't do the weightlifting you want to do, but you are making some progress. And it might not be as fast as we want it to be right now, but we're moving the needle in the right direction. So something that, A-level evidence from the CPGs, I think it's something we should definitely be considering using. What do you got on that, Dan? Do you like outcome measures?
Yeah, I think you nailed it. If you look at most of the clinical practice guidelines, they almost always recommend outcome measures, and it's usually a very high grading, right? So I think you can almost always make the argument that you should be using these. And I think they're helpful for a variety of reasons. So the first of which, I think you already, like I said, you nailed it. For these pathologies, especially frozen shoulder, it's a long time horizon. And one of the things that happens with patients is that progress is so slow, they get very frustrated. And it's hard to know if you're making any progress whatsoever, right? And I think that, and we'll go over this a little bit later, but oftentimes if people stop making progress, then we're starting to think, okay, is it time for a different intervention? Do we need to do, let's say, an additional injection? We'll talk about hydrodilation, suprascapular nerve block. There's a couple different things that patients can kind of go down the pathway of, or surgery, right? So part of it is if you're making zero progress whatsoever, the outcome measures are going to help to show that and maybe guide the next steps, right? Let's say it's been 3 months, made zero progress, right? We're at the point where things should be advancing. What's my next stage, right? Or people actually are making progress. It's just that it doesn't seem like it. The outcome measure can help to guide that. What I will say is that I think if you work in network as a physical therapist and you've been dealing with insurance companies for the majority of your career, you've probably been burned at some point, right? So essentially, outcome measures are hard because I don't think patients always understand how to do them appropriately. Essentially, patients think that I should fill out this outcome measure as bad as possible to show I have a need. And then when they have to fill it out again, they'll fill it out as bad as possible. So it shows they still have a need. And insurance companies look at that and they say, look, you made no progress. You've actually gotten worse. And we're going to cut you off from physical therapy, right? So oftentimes you have to even coach your patients on how to fill out their outcome measures. And then what happens is that they're not accurate, right? So patients are trying to game the system. And I think the other reason why outcome measures get a bad name for us is that they don't often capture the patient's limitation, right? I have a CrossFitter that comes in, they have shoulder pain, they can't do what they want to do. They fill out a quick dash, it looks like they're 100% and there's no problem whatsoever. Insurance company is not going to, cover them. And the other part is that it's not going to capture any improvement if there is any over the course of time. So I'll often favor things like patient-specific functional scale over doing one of these other outcome measures. But the other piece is that they certainly are a good idea with patients. I just don't want to give the idea that, we hate outcome measures and think they're terrible. I just think that given the population that we work with, they usually have a little less utility. But then again, there's outcome measures for more athletic folks as well, right?
All right. So key number 2 is conduct a stellar examination. And this is going to help with the diagnosis. And it's also going to help guide our treatment, obviously. So um, I think the first key is determine the level of tissue irritability. So generally there are 3 stages, like we spoke about in the previous frozen shoulder podcast. Stage 1 can last anywhere from 2 to 6 months with moderate to severe pain. It does start to progress into more pain as that stage progresses. And then stage 2. So again, we had looked at, there's a few different sources here telling us, 4 stages, 3 stages, but these general overarching stages are important to keep in mind. So from this paper, stage 2 is 4 to 12 months in duration with moderate pain. The pain is improving, but the motion's worsening. So that's that general trend here is early stages, a lot of pain, only a little bit of loss of motion. And then those later stages, pain's getting a little bit better, but they're getting stiffer and stiffer. And finally, in that third stage, they start to kind of see the light, and both the pain is minimal and the stiffness is gradually improving. So go ahead and try to determine what stage they're in here. We did talk about this a little bit in the previous episode as well, but I think a more helpful approach than trying to figure out exactly what stage they're in is trying to figure out the level of tissue irritability. So that's something that we will get into talking about, but I think that will allow you to better guide your treatment than nailing the stage, because I think on paper, these make a lot of sense, but when you see a person, oftentimes they're not fully showing all the characteristics of one stage, perhaps, or they're overlapping in one of two or three stages. So I think there is a lot of utility in finding out the level of tissue irritability for this and many other pathologies that we see as PTs for sure.
Yeah. And I think like Kevin said, you don't necessarily have to nail that stage of tissue irritability. Like this is a stage 2 or this is a stage 3. I think a lot of it is just, you really have to respect this injury, maybe more so than other types of injuries. Big thing is that we have a bit of research to look at kind of aggressive rehab protocols versus very easy rehab protocols. I think one of the studies was entitled Aggressive Physical Therapy versus Watchful Waiting or something along those lines. I'll put a link in the show notes if you guys want to check that out. But what they found is that if you push these things too hard, too fast, versus you watch them and just give gentle, easy range of motion, so that watchful waiting is not really true. But if you do easy exercises versus hard exercises and really push that range of motion to be aggressive, pushing the range of motion to be aggressive does worse. So the way you figure out the tissue irritability, in my opinion, is you take them through a few exercises. We do gentle range of motion exercises. You see how they feel. You push them a little more, you see how they feel. And essentially, you just meet them where they are. Like Kevin said, you do the same thing for any other diagnosis. But I mean, the thought for a lot of folks might be, hey, this is stiff, we need to push it. That's not really the case, especially if they're really irritable. You're going to make them worse. We know that.
All right. So getting into the tissue irritability. So these quotes were taken from a study that was looking at this. And what they said was an expanded classification system that includes both the pathoanatomic diagnosis and a rehab classification based on tissue irritability is going to be important. For the rehab classification, 3 levels of irritability are proposed and defined with corresponding strategies guiding intensity of treatment based on the physical stress theory. So again, the tissue irritability concept could be pretty important here. Like Dan talked about, if we flare these people up, it's a little worse than if we flare people up with some other conditions, perhaps could cause some regression or prolong of symptoms. So it can guide the intensity of the treatment. And then this theory that Laurie Michener and Phil McClure came up with on tissue irritability was actually validated as used by physical therapists. So if a few different PTs are trying to classify someone's tissue irritability, we find that it is, validated in the research. There's good inter-relator reliability, which I think is pretty cool. So there appears to be acceptable reliability and a strong relationship between patient-reported outcome measures and therapist-related tissue irritability. And that was in this STAR shoulder irritability rating system. And it could be one way we can use tissue irritability gathered during the subjective and objective exam to guide our treatment. So we'll get into this a little more in the next slide, but what do you think, Dan? Tissue irritability, good or bad?
All right. Yeah. I think that obviously working towards tissue irritability is going to be important, and you're going to get a lot of information during your clinical examination. So essentially, when you take them through an active range of motion and passive range of motion assessment, and then you get them on the table, you look at flexion range of motion, external rotation in multiple planes, internal rotation, you'll get a good idea of how irritated this person is. And I think you can use those measurements to dictate how you progress over the course of time. So obviously, it's good to document those firsthand, but also how you start from a treatment perspective. If you know someone's extremely limited with external rotation, give them easy exercises for their level of external rotation. If they can't bring their arm up to 90 and externally rotate because it's so dang painful, I am not going to give people any sort of stretching overhead, right? I'll start with easy stuff, elbow at the side, work that range of motion a little bit. As they start to build a little tolerance over the course of time, I'll bring them up. But I'm not going to do that from the get-go because that's going to cause a bunch of problems, right?
Sweet. And I think for our viewers here that are watching, I think this chart, I know it's maybe a tiny bit blurry, but I think it is really helpful. And um, this is in the STAR paper. So this is something that we could look at for classifying tissue irritability in patients despite the pathology we're looking at. So, very broadly, we have high, moderate, and low irritability. And each of these boxes here represents the criteria for putting someone in those categories. So, just for example, high irritability, someone with greater than or equal to 7 out of 10 pain. So this person's pretty flared up. They have consistent night pain or pain at rest. They have high levels of reported disability, perhaps on one of those outcome measures we had talked about. The pain occurs before end ranges of motion. So, like Dan said, if you're getting someone on the table and you can barely move their arm, might be someone with high tissue irritability and not someone we're going to give aggressive exercises to. We also see active range of motion, perhaps being significantly less than passive range because they're in so much pain, they're unwilling to move their own arm or whatever other joint we're talking about. But in the case of frozen shoulder, obviously, how much they're willing to move their own shoulder. Next, we could classify someone with moderate irritability if they report moderate levels of pain, which could be looked at and rated as between 4 to 6 out of 10. These patients might still have pain at night. They have moderate levels of reported disability on one of these outcome measures, and the pain's occurring more at the end range of motion versus that early or middle range of motion. And here you might see equal active and passive range of motion. And finally, folks we could categorize as low irritability. They usually report minimal levels of pain, so less than or equal to or 3 out of 10. They have no night pain or resting pain. It's really only with their activities of limitation. They have levels of reported pain and disability that are low on those functional questionnaires. And pain might only occur with overpressures at end range of motion. And again, with active versus passive, we're going to see pretty symmetrical ranges of motion for these folks. So again, these are kind of important to keep in mind for a lot of different diagnoses. And the reason why I'm introducing them now is because the frozen shoulder clinical practice guidelines recommend basing your treatment off the level of tissue irritability. So rather than those broad stages that we talked about, that I do think are important to know, guiding treatment is going to be based on one of these three groups that we might be able to put somebody in.
I think these are great. Looking through these, I was like, man, these really solve all my questions I would have, and I feel like I can very easily bucket my patient to one of these. One thing I will say is that for some of these patients, especially when they're very irritable, they talked about active range of motion, passive range of motion being very different in the earlier stages or high irritability. One thing I will say is that sometimes I find that folks who are restricted in both of these, and it's because they have a very empty end feel. So when you're arranging these folks, what you'll often find is like, I feel like there's a lot more range of motion, but you're just guarding. You're not letting me get to end range. And that makes a lot of sense. If they have a lot of inflammation in that area, your body is basically just trying to protect you. So you might not always find that they have way more passive range of motion when they're very, very irritable. It might just be that your body has more available passive range of motion. It's not actually super stiff, but you can't access that just because the patient's guarding. And I would actually recommend you don't blow through that empty end feel because you're going to make your patients really mad. But I think the other part is you don't necessarily need to have that information. Just keep in mind that's probably what you're going to end up finding.
Awesome. So, key number three, kind of based on what we were just talking about, is selecting the appropriate intervention for the level of tissue irritability or where this person is in their frozen shoulder journey. So, these are from the clinical practice guidelines here. And what we're looking at for patients with high irritability is that modalities are actually indicated. And it does seem like these can be helpful for these folks, probably in the short term for giving you a window for doing some exercise. And I think it's worth trying. You do one of these things and someone says, hey, I feel a heck of a lot better. I don't think you have to be afraid to use modalities, and they are supported by the clinical practice guidelines. So I think you're on firm ground if you want to use these. So these CPGs recommend heat or e-stim for pain. And again, probably pre-treatment might be best, but if they feel good and they want to use this at home, I think that's totally fine too. I think a big part of what we can offer in this phase is education. So, a lot of times it's not what you just add for stuff at home, it's what you modify at home as well. So, we can be educating these people to find positions of comfort and positions to avoid. If they're going to be put in certain situations or trying to do certain activities that we know they don't have the range of motion for, we can try to help them find another way to do it. I think one of the most simple things that we as physical therapists learn in school kind of right away is like, when you're putting on your jacket, you put in the involved side first. And these are things we can help educate patients on that they don't know on their own. And it can kind of go a long way in reducing their pain. So, um, for manual therapy, some soft tissue with the muscle guarding is probably something that could be helpful. The CPGs do recommend low intensity joint modes for reducing pain and perhaps improving range of motion. And then doing some passive range can be helpful. And like Dan had said, these folks are probably going to be in an empty end feel, and that's okay. We just want to get the joint moving. It can help them feel a little bit better. We're not cranking into end range, but some passive motion, I think, can feel good for the patient to get things moving a little bit. So I think those are some interventions we can think about. Again, taken from the CPGs for patients with frozen shoulder and a high irritability phase.
Good stuff. A couple thoughts. Some of the research shows things like table slides, pendulums, using a PVC or a dowel, supine, external rotation, active assist. I like to do flexion in that same position as well. One of the things I often do for these folks is low level, high frequency exercises. And I think we're getting some good neuromodulation. These folks don't tolerate high intensity or big stretching, but oftentimes it feels pretty good to do a low level of exercise all throughout the course of the day. So a couple cues I give my patient when they're exercising is say, hey, push to the point where you feel a little bit of that barrier or that pain start to kick in, then back off. Don't blow through that pain barrier. And we just do that with all of our exercises frequently throughout the course of the day. So I might give my patients like somewhere between 1 and 3 exercises to be performed at least once a day, but more likely doing this multiple times per day, once in the morning, once in the middle of the day, once in the evening, and if possible, all throughout the day, maybe once an hour, just trying to move the shoulder as much as possible without irritating or aggravating it. Now, one more thing I will say before we go on is that I will be filming a video where I talk about my favorite exercises so you can see exactly what they're going to be. I'm trying to describe it here, but not always the best, right? Be on the lookout for that. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Awesome. So then in regards to moderate irritability, what are some good interventions? And again, these are all from the clinical practice guidelines. So we might taper off modalities. I think it depends on the person, but we can think of this as an as needed type thing. If the person finds great benefit from it, why not add it in at this phase? We're continuing to educate on progressions at home with different things they're doing around the house and ways they can get back to some of the more intense things they like to do at home. So some good education there, always checking in on like what are you struggling with at home, and kind of brainstorming with the patient if there's anything you can offer them as far as strategies for performing those things. We're still in a phase where manual therapy is going to be helpful, so we can progress our joint mobilizations from those early low level joint mobs that are focusing on pain relief to perhaps a little bit more moderate intensity range of motion joint mobilizations. We can progress the amplitude and duration, so maybe like a grade 1 to a grade 2 or 3. But you can use the pain monitoring model here. So a little bit of pain is okay, but with these folks, we don't want them to be in significant pain for the rest of the day. We probably flared them up too much, and we might have to take a step back with our joint mobilizations. As Dan had said, stretching can be really helpful in finding a frequency that works for the patient. So usually very frequent stretching is something that can feel good, but the intensity could be low. So you're still in a phase where, perhaps it's a high volume of movement throughout the day at a little bit lower intensity. And then in this phase, we can start, with a moderate irritability patient, we can start incorporating some neuro reeducation. So the CPGs had recommended range of motion into normal scapulohumeral mechanics when reaching. So working on perhaps like, I don't know, mirror feedback when someone's lifting their arm overhead, not getting this huge upper trap shrug where they're using a bunch of compensatory muscles. We're kind of slowing things down with this person and trying to get them to feel their shoulder again and learn how to move it kind of segmentally. So that's something we can add in this phase as well.
Another thing I will say is that we have a bit of research to show that strengthening exercises can actually be more beneficial than just mobility exercises. And I think in this phase, folks are getting to the point where their pain levels are low enough, they might be able to tolerate a little bit of kind of mid-range strengthening. Certainly, you can start off with things like isometrics if someone's really painful. So essentially just kind of elbow at the side, resisted external rotation, internal rotation, flexion, extension, adduction, abduction. I call it a 6-way isometric. But usually you can get away with a little bit of resisted internal rotation, external rotation with some TheraBand, right? Maybe a little bit of resisted flexion if that range of motion is okay. One of the things you might find is you guys may have a significant shrug sign. So because they're so stiff within the capsule, so painful, and sometimes they'll move straight from the shoulder blade, just like Kevin was saying. So I think it's important that once you start applying some of these strength exercises, let's not build bad habits, right? Let's choose motions that are more through a partial range of motion. They aren't causing a ton of compensation, a ton of pain, right? But I think it's now appropriate to start incorporating a little bit of strength alongside with your mobility exercises, then actively trying to work on motion, making sure you don't have that huge shrug sign, right? We're not moving entirely through the shoulder blade. We're getting some motion through that shoulder joint without forcing it, right? Because we force it, we're still in a bad place. That can make us go backwards.
On this slide, we have a bit of a typo. So instead of high irritability, we're in the low irritability phase here. So if you're categorizing someone with that low irritability, it's probably time to move away from the modalities. So they don't need any of those. For the self-care and home management training, we're continuing to educate them on how to reincorporate high level activities at home and how they can get back to the recreational activities that they've had to modify since the onset of this frozen shoulder. For manual therapy, if we're still seeing loss of range of motion, we can kind of transition to high end range joint mobilizations. So maybe more of that grade 4 with a high amplitude and longer duration to try to improve range of motion. Again, we're going to see pain pretty low, and we want to make sure that pain continues to stay low. And as we get more aggressive with our interventions, they're not flaring patients up. We can progress stretching, perhaps to stretching at end range, again, without excessive pain. But what might work well for these folks that, we definitely utilize at Champion is a kind of low load, long duration stretching. And just be sensible. Make sure that the person isn't flared up after. You're not regressing at all, but something to consider that can be really helpful for improving motion. And what we'll do for that is usually bouts of, maybe 5 or 10 minutes or so at a certain range of motion that the patient can tolerate, and they're just hanging out there. And if you can get that going a few times throughout the day, it can make quite a bit of difference in the range of motion. And then we're continuing to focus on just, quality movements as we get into this phase. So a little bit of neuro re-education, and then of course a bunch of strengthening. Right, we're getting back to the activities that this patient really wants to get back to. Doing more in the gym, in the range of motion that they have, and progressing back to kind of full activities without restriction. So we can be pretty aggressive in this phase with our exercises. We just want to make sure we're respecting the pain and kind of heading in the right direction.
I feel like this is kind of that phase where physical therapists can use their full toolkit, right? So before, really holding back, we can't do a lot of things we normally would for a stiff person. But now we're getting to the point where everything's kind of on the table. So I will start to incorporate more traditional stretching or static stretching at this point. So the patient can handle it, something like a pec stretch in the corner or the pec stretch through a door. Just keep in mind, a lot of these folks are still going to be very stiff, so it might be hard to stretch from that position. We can do the same type of pec stretch with the elbow at the side into external rotation and just holding 30, 60 seconds at a time, a couple of different sets. I will also do some weighted stretches at this phase if a patient can handle it. So let's say your back is on a physio ball and you have some light dumbbells in your hands and you're going into, let's say, a T position or a U position or a Y position. So getting a little additional load to help with our stretching. We can either hold a little bit of end range or just go to end range and then back off again. This is also where we'll incorporate a little bit of a low load, long duration stretching. And this is what Kevin just kind of mentioned. In terms of how long you have to hold these, it's a pain in the butt, but probably somewhere between 20 minutes and 60 minutes at a time. One of the things that I learned from Champion, I think the guys like Mike Reinold, Lenny, and probably Kevin back in the day, is just you take your patient, have them lay on their back, you support their elbow, try to get them in the scapular plane a little bit, take a TheraBand or a light dumbbell, put it in their hand. So it's pulling them into a little bit of external rotation, put some heat on that shoulder and let it sit there for a long period of time. So we're talking 20 minutes up to 3 times a day. It can be a lot. But if we're looking for that true tissue creep, we need a lot of time to gain that. So this is one of my favorite interventions for patients with frozen shoulder. But if you incorporate this too soon, you're going to hurt your patient. So you can also do this into flexion as well. But usually it's external rotation is most limited. And anecdotally, if you're improving external rotation, it's probably going to carry over to flexion a little bit as well. What I'll do with my patients is that I'll do a lot of measuring before and after, come in the clinic, do a lot of mobilizations, really work on the external rotation. I also find that the flexion actually cleans up a little bit too. So when we're trying to improve external rotation, we're probably helping all the different directions as well. So, and just like Kevin said, at this point, we're advancing their strength. We could probably go a little bit more towards end ranges of motion. I'm a big strength and fitness guy. I'm always trying to push this on my patients. Most of my patients want this anyway. During this stage, I feel like I don't have to hold them back so much anymore. The one thing I will say is that they're going to still have compensation with end range of motion motions. So thinking about things like overhead press, snatch, that type of thing, it's going to look pretty bad still just because those positions need a ton of mobility. And oftentimes the folks that are getting frozen shoulder are a bit older and stiffer anyway. So now they've got one stiff side and one very stiff side. So I would still say, like, feel free to start working back to a lot of those positions, but keep in mind there's going to be a lot of compensation, and I probably wouldn't push those positions for like an overhead press or a snatch position, overhead squat for the CrossFitters out there. until they're looking pretty symmetrical. Because otherwise, I think they're just building bad habits, kind of like Kevin alluded to.
For patients with frozen shoulder, do you think physical therapy is enough? Just PT alone? Can we do it on our own?
Ooh, I'd like to think so, but in my heart of hearts, I don't know if it is enough.
Yeah. I think all of this that we've talked about, it's so important, I think, to get this diagnosis right, because if you're trying to plug away with just physical therapy, this is one of the conditions where you might not be getting the best outcome for your patient. So I do think it's important for us to know that combining physical therapy with other treatments here is so important to get the outcome the patient wants. So this quote here is taken from one of the papers that I cited. And in general, physical therapy is simultaneously combined with other treatment modalities. As a Cochrane study concludes, there is little overall evidence to support physical therapy alone in the treatment of adhesive capsulitis or frozen shoulder. So, based on a network of 9 studies, um, it found that a steroid injection combined with physical therapy was the only treatment showing statistically and clinically significant beneficial treatment compared with placebo for short-term pain. So, we've talked about this throughout, but combining physical therapy with a steroid injection, when you can do that, if it's a patient who doesn't have diabetes, or you said some, concomitant rotator cuff pathology, perhaps, it can be very helpful for these folks. And it's better than doing just the steroid. It's better than doing just physical therapy. It seems like that combination of the two really gets better outcomes. And a Cochrane review that was looking at that combination showed that manual therapy and exercise was not as effective as a steroid injection. So maybe the injection alone is actually better in some cases than just physical therapy. But why do one or the other when you can do both, right? And then patients with manual therapy and exercise, again, for function, didn't improve as much as the patients who just got a steroid injection. So again, maybe because there's so much actual pathology occurring in the shoulder here, and it is a active inflammatory process, they are laying down new blood vessels. Perhaps that steroid injection is interfering with those things, and it's relieving a lot of pain and improving function. Um, but I think, again, one more note on this study was saying that 46 out of 100 patients reported successful treatment with manual therapy and exercise, but 77 reported success with just a steroid injection. So if you're going to do one or the other, which I don't know why you would, but 31% better improvement with the steroid injection. So it's definitely something that we need to consider here, is that we alone probably can't provide the best outcomes, but we can in combination with a good referral to a doctor who sees frozen shoulder quite a bit.
Yeah, this is an anecdote, and obviously it's evidence based, but cortisone injections help so much for these folks. You have a patient that hates their life; it's so painful. They get the injection, they feel amazing, and the range of motion gets a lot better. So I really think this cortisone injection with physical therapy is kind of this kind of match made in heaven. It's so helpful for patients. Patients feel great. You got to keep in mind these guys don't feel very good, and they're getting more and more restricted. And it's kind of like, what the heck did I even do to my shoulder for this to start happening? It happens out of nowhere, and it's this multi-year process. It really, really sucks for patients from a psychological perspective. Cortisone injection can be extremely helpful. And the other thing I will say is if you've ever worked with a frozen shoulder without a cortisone injection, that stinks. It's a lot harder for the physical therapist as well. So this is one of those, I would say, rare cases, although I think you should always work with a good surgeon, good shoulder specialist. But it's one of the rare occasions where it's like, all right, I'm sending you straight back to the doctor. Let's get a cortisone injection. Let's get this thing going, right? Almost always with other pathologies, I'm trying it depends. If I have like a shoulder dislocation, I'm not going to just treat this right away. I'll probably send back to the doctor, but almost always I'm starting with physical therapy. This is one of those cases where I'm sending back to the doc, right? Maybe we treat him a little bit that day, but say, you need to go back to your doctor. Let's get a cortisone injection. And oftentimes I'm getting referrals from doctors from a patient that already had a cortisone injection, right? So you're definitely going to see that as well, right? The other thing that I've been referring patients to get a bit, we have a couple of local docs. Dr. Eric Laska is one of the guys who does these locally, is that You can look into hydrodilations or hydrodistension procedures, which can be a little bit painful for patients, sometimes not tolerated well. But essentially what they're doing is they're filling up the shoulder joint with cortisone and fluid, right? And they're showing sometimes better outcomes because we're kind of distending that capsule a little bit, stretching that capsule, and we're putting a lot of cortisone in that area as well. And the research shows that it really has good outcomes. So if you haven't heard about that, I would look into it, right? Because it's not really well known, I wouldn't say. The other treatment that's showing some pretty good outcomes is a suprascapular nerve block. And again, it's an anecdote, but a lot of patients say they really love it. I have a lot of physical therapists I've spoken to. They're like, man, I've had some patients try the suprascapular nerve block and they've done amazing afterwards. So there's a couple other options for you. And the last thing I will say is that if your patient's making no progress whatsoever, you can consider a manipulation under anesthesia. I would say this is kind of your last case scenario. And if you look at some of the literature, I think it's pretty similar doing the manipulation under anesthesia versus cortisone with physical therapy. So it's definitely not my first go-to. It's definitely more invasive, definitely more risk of causing a complication from that. But the other part is that if you're not making any progress whatsoever, then I've seen patients that do pretty well with that as well. So you have some options for you if you don't, have progress with the cortisone with physical therapy.
Sweet. So, we can speed through this slide, but these are just a couple other studies that are showing that PT with an injection, back to the corticosteroid injection, leads to better improvement than PT alone in shoulder pain and in shoulder function. So, again, something to consider. You had touched on a few of these things in what you were just talking about, and I think you nailed it. So, hydrodilation wasn't something I had heard about. And then, actually, after we did these slides, I did see a little bit about it on social media. So it's kind of interesting that I start hearing it floating around a little bit. But it does seem like hydrodilation with or without a steroid injection may be more effective than just a corticosteroid injection alone at improving pain in the short term. So, perhaps something to be on the lookout for is if we should be referring our patients for this type of injection. I think worth doing some reading and learning more about. And then, as Dan had mentioned too, surgery is an option. Sometimes they'll go in and they'll, release the capsule, or they'll do a manipulation under anesthesia. And this is from that reference there is from the Frost trial. So that's a paper you might see. And they were looking at the difference in outcomes between physical therapy with an injection or patients who have a surgery. And in the long term, there really doesn't seem to be a difference between the two. So why not avoid surgery if you can? It doesn't seem to have superior outcomes. It can be helpful, but again, it doesn't seem to be more helpful than just PT and an injection. So definitely worth trying that first. Surgery is there for folks who might need it, but we always know surgery comes with other risks. So if we can avoid it, let's definitely try those first two things first, some type of injection and PT. And then that's an option down the road if this person's just really not showing any progress.
Yeah, for sure. We want to be really patient with these patients. We know it takes a long time to get better anyway. The other thing is, and I think a lot of doctors are not doing this anymore, right? From a surgery perspective, you can range the shoulder under anesthesia, you can manipulate it, kind of a joint mobilization with it, and you can be a little bit more precise with kind of cutting some of the adhesions. Some of the older procedures that a lot of surgeons would do would potentially tear the rotator cuff and part of the labrum too. So when they say that there's a higher risk of complications, they're not good complications, right? So just like Kevin said, we're trying our best to get this done more conservatively. We don't want to go in for surgery if we don't have to. But what I will say is that I've certainly seen some folks have success with this. So if you're making zero progress, it might be an option in the future for your patients. So now you know some good treatment strategies for your patients with frozen shoulder. I want to show you the exact exercises I like to use with my patients with frozen shoulder. And I have a video for you. And oh, look, it just popped up over top of Kevin's head. It's right there. Go ahead and click on that link, and I'll go over my exact treatments I like to use with my patients with frozen shoulder. Click on it, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously.
And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step by step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.